telemedicine work started with our Dean partners, and so we worked closely with the charge nurses and the manager at the clinic to understand the technology and what they were using. The people seemed to embrace it. They loved the fact that they can stay home. And so we took that a step further and worked with our partners in St. Louis to bring that technology here.
From a clinician standpoint, providing care to patients at sites that they don't physically go to and provide that specialty care, the overall care for that patient when they have a specialty type problem is going to be improved. And when you do that, there's cost savings because it's more efficient, cost-effective care.
Every patient who has intensive care services or needs intensive care is automatically given that link to the telemedicine. And when the telehealth consult rings in, they actually have a camera that wheels around and talks to the patient. A little doorbell rings so they know when we come into the room with telehealth, so the camera can zoom in on anything they want to see. They might see a patient once or twice, or they might see a patient every 10 minutes if that patient is acute. They can also access all the technology, so they see the patient's medical record, all the lab values, the telemetry strips, all of that they have access to.
And then we have a nurse in the room. If I need the nurse to take down a dressing or to look at their PICC line, their IV, for example, she can do that for me. So it's actually more efficient, to be honest with you. Normally, I see the patient, I walk out of the room, find my nurse, and we need to do X, Y, and Z, and then they go in that room. Here, it's all in one.
The first patient that we had, I remember they were in their probably 80s, and I thought they would be absolutely against it, and they thought it was so cool. They were like, look at this, we're on TV, and they're waving to the doctor and everything, so that was neat.
When we schedule patients, we tell them that that particular visit is going to be a telemedicine visit, and they have the option to either have that telemedicine visit or see me physically the next time I'm up there or come down to Madison. So it's their choice. And it's pretty unusual for someone to not say okay to the telemedicine visit.
This is a small community. We're about 12,000 people, and the drive to Madison is a big deal for people. If you think about the patients we care for, a lot of them are in their 80s and 90s, and their kids are in their 70s. So it was really important for us to bring those services here to the hospital. Our young nurses have that 24-hour critical care nurse support, and our physicians have specialists. They're all board certified, they're fully credentialed here, so they can do anything from give us advice on where to start an IV or how to run a central line to actually running patient care, including a cardiac arrest. We're able to say we can take more acute patients, and that helps build clinical skills for our nurses. For all of SSM, I think it's a win-win. We partner with Janesville and St. Mary's here and draw on each other's expertise.
What I'd like to do for our department and our telemedicine program is to expand it to areas that we don't physically go to at all. So then we're basically expanding our footprint where we can provide services.
When Joint Commission was here, they told us we had one of the most wired small hospitals that they've surveyed. And so for SSM to have that reputation and to build on our expertise that we've gained for other small hospitals, I think that's a real win.